frontal chest radiography of skeletally immature individual who presented with cough, where I can see there is an right upper lung zone opacity. It's not silhouetting the right cardiac border. I'm checking if there is any other associated abnormalities, but clear left lung field, no pleural effusion, no pneumothorax or pneumomediastinum. Heart and mediastinum appear within the normal limit. I'm checking the bone for any bony abnormalities. The bony thoracic cage is unremarkable. So in summary, this is a case of right upper lung zone opacity. Given the clinical history, I will put infective etiology on top of my differential diagnosis, and I like to correlate with the clinical presentation regarding the fever and if the patient is unwell and if there is any increased inflammatory markers. And I'd like to check the previous images if it's available. I will convey my findings to the referring physician and recommend a further follow-up after proper medical treatment after 4 to 6 weeks after starting the treatment.
So what would you tell the team? What would you tell them over the phone, or what's your diagnosis?
This is the diagnosis will be rounded pneumonia.
Yes.
As an infective etiology based on the given clinical history, and I will recommend a follow-up after 4 to 6 weeks after starting the treatment.
Yeah, so that's a simple, just a rounded pneumonia. Do you know what's the commonest organism?
Streptococcus pneumonia.
Yes, so that's a strep pneumonia. So follow-up, it's a bit controversial here in the UK. We don't tend to do any follow-up unless they're not clinically better. So here in Birmingham Children's Hospital, we don't request a repeat, but some places do request, a repeat in 4 to 6 weeks, just to ensure that it's resolved. Okay, so that's a rounded pneumonia, strep pneumonia. It's a community-acquired pneumonia, so strep pneumonia would be the commonest. Less other commonest causes, Haemophilus influenzae, but we don't see it these days because of the vaccination. And follow-up, yes, it's appropriate doing it in 4 to 6 weeks. Okay, so next case. So this is another child, and just present it again with shortness of breath.
Okay, this is frontal chest radiography of a skeletally immature individual who presented with a shortness of breath, where I can see checking both lung fields for any opacities, but I will go systematically and review check the review areas. The supraclavicular regions and hilar regions and the left retrocardiac regions and the subdiaphragmatic regions are clear. So I'm checking the bone for any bony abnormalities. No gross bony abnormalities. I'm checking if there's any associated soft tissue lesions. I could not appreciate any gross abnormalities. However, I'd like to correlate with the lateral view if it's available.
So I don't have a lateral view, but I'll just help you with the history. So he's just having cough for 8 weeks. So he's a child with a cough and shortness of breath for cough for 8 weeks and shortness of breath just progressively getting worse.
Okay. Cough and shortness of breath.
Long history. So it's
long history, yeah. Okay. In my routine practice, I'd like to use zooming tools. As by zooming, I can see that there is a tubular structure is running parallel to the right cardiac border and running down to the subdiaphragmatic level, and it's not silhouetting the right cardiac border. So in this case, and based also on the given clinical history, I will put partial anomaly pulmonary venous return or scimitar syndrome on top of my differential diagnosis. Other differential diagnosis could include an sequestration, pulmonary sequestration, or
where would you see? So where would you see sequestration? So just a bit more common stuff. So he's a pediatric child with chronic history. Commoner things are much common. So what would you think of apart from sequestration? They're all valid differentials, but just things are, what are the commonest things in a child with a long history? So what would you be suspicious of?
Okay, sequestration. I will sequestration on top of my differential diagnosis.
Okay. And if I tell you there is no evidence of sequestration, so something much more simple. So children, what do they do? What do they put in their mouth?
Scimitar? Scimitar syndrome?
So it's not a typical of scimitar. Let me just make it a bit easier for you. So so young children, 3 years old, 2 years old, when they're playing, what do they put anything in their mouths? They play with the Lego and everything. Does it ring any bell or anything?
Yeah, okay. So I will put okay, I will recheck the the both lung fields. I can see that there is a little bit increased lucency of the and little bit hyper expansion of the right lung volume.
Yes. So
So I will yes,
yeah.
a foreign body ingestion or inhalation could be a cause as a cause of increased lucency of the right lung field.
Yes. So
To confirm my diagnosis, I'd like to put the patient on the affected side to see if there will be still hyperinflated
so how
in
would you
the
know which side would you think, or how would you know which side is affected?
yeah. I put the suspected side on the dependent position.
Yes. And what would you be looking for?
For the air trapping.
Air trapping, yes. So this is just a quite subtle, subtle finding. It is quite rotated, but the right-sided, is hyperinflated. And can you see just the splaying of the ribs? So just compare the
Yes.
posterior ribs. So there is splaying of the ribs, no flattening of the diaphragm. So when you're presenting it, say, I can see that, it is hyperlucent, the right lung, perhaps maybe not convincingly, but the splaying is quite evident here. So that indicates there is increased volume within the right side and no flattening of the hemidiaphragm. And as you said, you'd confirm that with, much more simpler. If the child is cooperative, what kind of film would you do?
With the maybe the
Expiratory film.
expiratory film. Yes,
Yeah,
yes,
so you'll do an expiratory film. And if they're not
yes.
cooperative, then you'll go to the decubitus. But just always think of a foreign body, pediatric patients, always, remember and think of foreign body as the first thing. And you just look for any evidence of increased lung volumes, as we discussed, by splaying of the carina, hyperlucency, or flattening of the diaphragm. So, yeah, well done. This is the next case, and that's an adult patient, a young adult patient who presented with shortness of breath.
Okay, this is a frontal chest radiography of adult patient who presented with shortness of breath, where you can see there is an tubular opacity, which is I can see it's parallel to the right cardiac border. I can see also there is increased density at the left retrocardiac region. Um, uh, However, there is no pleural effusion, no pneumothorax or pneumomediastinum. Heart appear within the normal limit. I'm checking the bone for any bony abnormalities. There is no the cardiac, thoracic cage is unremarkable. So I'm suggesting that there is an opacity at the right paracardiac region. I'd like to correlate with the previous images if it's available for comparison, and recommend and compare with the previous images, and recommend a contrast a CT chest for further investigation.
So
I can
what's your diagnosis? So what's your differentials?
Yeah, I will put also sequestration on top of my differential diagnosis at the especially if the patient has a repeated chest infection. Um,
Okay, so you said you've correctly picked it up. It's the right heart border appears slightly irregular with an opacity here. So what's something just simpler, keep things a bit more simple. So common things are much more common. So what would you think of when you see the right heart border a bit ill-defined? What would you think of?
um, and a right middle lung lobe opacity like consolidation or collapse.
Yes. So yeah, well done, well done. Yeah. So and how would you differentiate? Anything else? Would you want to consider or important negative when you see an irregular or an ill-defined right heart border? So you'd have three differentials. What is the third one?
The pectus excavatum.
Yes, so very well done. Yes, so these are your three, So right middle lobe consolidation or collapse or pectus. And then what would you say? Just the important negatives to say that, do you know what? I looked at the posterior ribs and the interior ribs.
Yes, as the seven-shaped ribs, where the posterior ribs are horizontal and the anterior ribs are vertical, giving the seven-shaped ribs. So I'd like to check the patient clinically
Yeah,
and or ask the clinician to correlate clinically if the patient has pectus excavatum.
okay.
And if the lateral view is available, I can check the lateral view for confirmation.
Yeah, so that's your lateral view.
It's
So what does it confirm?
It confirms that there is an opacity steen projecting over the heart shadow,
Mm,
uh, which is in keeping with right mid lung lobe collapse.
yes, so well done. And what would you do management-wise?
Uh, um, I'd like to. I'm suspecting that there is an endobronchial lesion, like an mucus plugging, especially if the patient is asthmatic, or maybe endobronchial carcinoid tumor if it's a young patient, or endobronchial carcinoma, or in other lesions. So I'd like to convey my findings to the referring physician and red flag this patient. For doing a CT, a contrast enhanced CT scan as soon as possible, and if there is any endobronchial lesion, the interventional radiology team could do an transbronchial biopsy.
Okay, so if it was an endobronchial lesion, so which bronchus would you think is involved?
The bronchus intermedius.
So if it is bronchus intermedius, what else would you see with it? Where else would be collapse?
The right lower loop.
Yes, so but here we can't see a right lower lobe collapse. So this is just a simple case of just middle lobe collapse, and it's just the importance of the lateral view. So this is just to show you that, you know what, the lateral view is very important. So whenever you see an ill-defined right heart border, you need to think of three things: right middle lobe consolidation, and as you said, collapse or pectus. And you just need to mention to the examiner and show them that you have the knowledge and say, you know what, I can't see any, vertical posterior ribs or a sharp upslope or a 7 configuration of the anterior ribs. So just to show them that you're thinking of, So, and the confirmatory is lateral chest X-ray. We don't do it quite a lot here in the UK. Not perhaps in Birmingham, we don't tend to do laterals, but it is done just to confirm that it's just a simple collapse. Okay.
Thank you.
Yeah, and that's just an elderly patient who presented with shortness of breath.
Okay, this is our frontal chest radiography in spine position of elderly patient who presented with shortness of breath, where I can see there is deepening of the left costophrenic angle, giving a deep sulcus sign, which is in keeping with an left pneumothorax. I'm checking also if there is any associated abnormalities. Clear both lung fields, heart appeal within the normal limit. The right costophrenic angle is sharp and well delineated. I'm checking the ribs for any abnormalities. Since there is no history of trauma, I can see that there is an left hilar irregular opacity, which is causing filling of the aortopulmonary window. So I'd like to check the previous images if it's available to check this lesion. And I will urgently convey my findings to the referring physician regarding the pneumothorax and the deep sulcus sign. And I'd like to do a contrast enhanced CT scan for further investigation.
Okay, yeah, so that's just a simple case. So the moral of this case, always read what's written. So this is an AP supine. So whenever it's supine, make sure that you check, because the pneumothorax can sometimes be tricky. This is a simple, just deep sulcus sign, which indicates pneumothorax. This is an emergency, or it is an emergency, so you need to get it across. Here there is just a rib fracture. So I didn't give you the history of trauma, but that's just what's given the history. So it's a shortness of breath. So always read what's written, on the film. But this is just a deep sulcus sign with fractured posterior rib. Well done. So shall we swap, or you carry on? I don't know. Candidate 2, are you?
Yeah, I'm here.
Okay, so I'll give you the history. So this is an elderly patient, 60 years old, who presented with cough.
So I'm presented with a frontal chest radiograph for an adult patient and AB view for a patient who presented with cough. And the most striking abnormality is an opacity projected over the right upper and middle lung zones with a reduced volume of the right lower lung zone and blunting of the costophrenic angle suggestive of right-sided pleural effusion. I can see in this opacity an area of lucency centrally. I don't see an air bronchogram, typical air bronchogram. In my routine practice, I will window this to confirm if this lucency branching with the pattern of air bronchogram in a patient who presented with history of cough and fever. The main consideration is an infectious process, inflammatory with consolidation as a pneumonia. If there is any previous images, I can compare with previous images. If no previous images and this patient have increased inflammatory marker, the main consideration is a pneumonia. And
What type of pneumonia would you think of? Is there anything in specific that you think of, given this appearance?
I think of a Klebsiella pneumonia that may give this appearance, and this need to be treated and follow up after treatment with the radiograph after 6 weeks to ensure appropriate resolution and non-underlying pathology.
So why did you say Klebsiella? Why did you pick Klebsiella?
I think because it's causing complete opacifications of the right upper lung lobe and maybe middle lobe.
And what else? So what's the buzzword, or what's the thing that is specific to Klebsiella that it would cause?
Lobar. Okay, someone give me the hints. Bulging fissure.
Yes. Bulging fissure. So this is just the classic, we don't see it quite a lot nowadays, but it's just characteristic for Klebsiella, which is the bulging fissure. So you're right, you picked up the pneumonia nicely. You've picked up that there is a lucency. So you could say to the examiner that you're concerned that there is perhaps maybe cavitation here. Maybe it is because developing a cavity, but the giveaway was just the bulging fissure here, which is in keeping with Klebsiella. Do you know any other organisms that cause bulging fissure?
Not sure if Streptococcus pneumonia also may
that's down the line, but the other organism that cause bulging fissure is Pseudomonas.
Pseudomonas.
Yes. Okay. So that's just a classic Klebsiella, how Klebsiella would do, which is just causing the bulging fissure. And it is, yes, you're right. We do a follow-up just to ensure that it's completely resolved, or sometimes they get complicated by cavities and lung abscess and others. Yeah. So so that's a young patient who presented with shortness of breath.
So I'm presented with frontal chest radiograph for an adult who presented with shortness of breath. And the most striking abnormality is tubular branching opacity projecting over the right upper lung zone. And there is slight loss of volume of the right upper lung zone compared to the contralateral side. There is no evidence of pleural effusion, no pneumothorax, and the left lung appears clear. Heart size within normal. there is minimal fullness seen at the hilar regions bilaterally, but no convincing lymph node enlargement. In a young patient with disappearance of a tubular opacity confined to the upper lung zone, I will be thinking of if the patient have history of asthma, of allergic bronchopulmonary aspergillosis with finger and glove appearance. I will correlate this with the previous images, and if the patient is known to have any history of asthma. The other consideration, if the patient is not known to have any asthma, will be bronchiectatic changes. Less likely, it's not the typical appearance like of cystic fibrosis changes, but usually it's bilateral and not unilateral. So comparison with the previous images and correlation if the patient is known to have any chronic disease is the next step.
Yes, so well done. You've picked it up nicely. It is ABPA, so it's a tubular finger and glove appearance involving the right upper, which is APPA. There is an important negative here that you need to mention. Then just show the examiner that you're actively looking for it. So tell them that I'm looking for, any evidence of bronchiectasis or tram track lines that extends from the hilum upwards. So this is just features of, bronchiectasis that you just want to show the examiner that, this is ABPA. I know it's associated with bronchiectasis, and I'm actively looking for any signs of bronchiectasis on this radiograph, which could be like ring shadows or increased bronchovascular markings, just to show the examiner, like, look, I know what I'm looking for. Okay, and as you said, it's you'd say, I'd like to visit the history and know if the patient is known asthmatic or any history of cystic fibrosis, as you said, but there are no changes bilaterally, as you said. So yeah, well done. And ultimately, bronchiectasis, do you know how we diagnose them?
On imaging, like we can do CT scan, but it's high, little bit increased radiation.
So the ultimate modality is, you're right, it's CT, and we do HRCT because it's most accurate. So radiographs are not ideal, and it won't tell you how extensive, but we tend to do HRCT just for the ultimate to see how extensive the changes of bronchiectasis.
Yeah.
Okay, so next case. So this is a young female. She's a pediatric patient. She's 13 years old, who presented with recurrent or periodic shortness of breath, and she tends to respond well to steroids.
Okay, so I'm presented with a frontal chest radiograph for a 13-year-old patient with recurrent shortness of breath responding to steroid, and the most striking abnormality is a diffuse prominent interstitial lung marking reticular pattern involving both lungs, and there is no zonal predominance for this abnormality, and there is no focal consolidations or collapse, no evidence of pleural effusion or pneumothorax. I can see that there is fullness seen at the bronchovascular marking at the level of the bilateral hilar regions. Looking at the bone, that I don't see any bony abnormality. So in a patient with chronic history of shortness of breath and disappearance of prominent reticular pattern bilaterally, I will be thinking of more chronic disease process with interstitial lung disease. This could be related to lymphangiomatosis with preserved lung volume. I don't see any definite nodule. In my routine practice, I will compare this with the previous images to assess the progression of the disease. With the history provided of response to steroid, I also think about an allergic hypersensitivity pneumonitis that usually respond to steroid. We'll compare this with the previous images, and if this patient had any exposure to allergens or such as pets or any non-allergen that make this disease worse, and correlated with findings.
What
CT
would you
scan.
do next? Yeah, CT. Yeah, do you want a CT?
So the CT scan on the lung window axial cut demonstrate there is ground glass appearance involving both lungs, mainly centrally, and while scrolling down, I can see that more involvement of the upper lung lobes, middle, compared to the lower. So the appearance is most with consistent with hypersensitivity pneumonitis as the cause. With this ground glass appearance, will convey the finding to the referring physician and advise the patient not to be exposed to allergens if there is any allergens known. This is mostly will be in the subacute stage of hypersensitivity pneumonitis.
Okay, yeah, so well done. You've picked it up nicely. So hypersensitivity pneumonitis do occur in pediatric patients. So that's a pediatric patient, and it's just ill-defined alveolar infiltrate as you've described it. And the CT confirms that there is some air trapping and ground glass nodules. So the management, I'm just going to touch a bit on the management here, how they manage these cases. They refer them to the MDT. Because why is that? Because there is a lack of standardized criteria for diagnosis. So usually the history isn't very clear to start with. And then we have the radiological evidence of it, but they still tend to go to MDTs. And in the MDT, how do they diagnose these cases? So it's always a problem to diagnose. So they end up in the MDT. So HRCT as here. So we have features which are supportive of the diagnosis, and then they tend to sit all together and then just discuss. So HRCT and then history of exposure. You need history of exposure. And then they tend to do bronchoalveolar lavage, lymphocytosis plus pathology. So the three features of HRCT with a history, as well as bronchoalveolar lavage and pathology, will grab the diagnosis. So hypersensitivity pneumonitis gets referred to the interstitial lung disease MDT. We have an interstitial lung disease MDT here. They'll all sit together. So it's radiological as well as history, as well as bronchoalveolar lavage and pathology. Okay. So this is an elderly patient, 50-year-old female with recurrent chest infections.
So I'm presented with a 50-year-old female with recurrent chest infection. The frontal chest radiograph demonstrate marked abnormality seen in the right lower lung zone with loss of volume and multiple cystic areas involving the lung, and blunting of the right hemidiaphragm as well as the costophrenic angle. There is also deviation of the trachea noted toward the right side, consistent with the volume loss on the right lung. I don't see similar abnormality or any abnormality on the left lung, and there is no left pneumothorax or pleural effusion. I'm looking for any evidence of pneumothorax on the right lung, which I don't see. And looking at the bone for any bony abnormality, the bone grossly looks normal. So in a female patient with this multiple cystic areas and volume loss of the right lower lung lobe and zone, and there is silhouetting of the right heart border and the right hemidiaphragm. I'm thinking of more chronic process involving the right lung, which could be
Yeah.
related to The only so I was thinking of usual interstitial pneumonitis, but the thing is only unilateral. It's not bilateral involvement, which is not typical in this case. Bronchiectatic changes of the right lung is in the differential. So I will compare these images with below, if any, available to assess the chronicity and the progression of the disease. If there is no better images, I will proceed with the CT scan for further evaluation.
Yeah. So, how do they look like? Did you maybe I haven't heard you? What do they look like? So you're right. You're going down the right route. So it is bronchiectasis. Can you tell what type of bronchiectasis?
They look like cylindrical and like circular in appearance.
Yeah. So cystic. You want the word is cystic, yeah?
Cystic, yeah. So not sure which type on this on the radiograph. I can put them maybe cystic bronchiectatic changes. So again, it is confined to only the right lung and middle and lower lung lobes, to a lesser extent in the lower lung into the upper lung lobe, with cystic bronchiectatic changes. So this could be related to congenital process.
So such as?
Not sure.
Okay, yeah. So well done. You've picked it up nicely. So this is, just an extreme case of cystic bronchiectasis, and they appear quite rounded. It is confined, to the right side, with some element of tracheal shift. So there is element of collapse. So that's why the right heart border, we can't see it clearly. And whenever we see, lower lobe zone or lower zone bronchiectasis, so your main differentials you'd be thinking of post-infective. Usually these patients has been exposed to repeated childhood infections. Most importantly, the whooping cough in young age would give you such an appearance, so you could say to the examiner, this is, lower zone bronchiectasis. I'm thinking down the line of post-infective. I'd like to clarify the history, if there is any childhood infection. Other, differentials could it be like primary ciliary dyskinesia? Could it be like an alpha-1 antitrypsin? All these are differentials, or obliterative bronchiolitis. So well done. Yeah, so that's just a cystic bronchiectasis. They really love bronchiectasis. And it cropped up in the exam a couple of times. So just know your differential very well for the bronchiectasis, and just try to be concise whenever you pick an abnormality, describe it well, look for any complications, and say to the examiner the causes of, just try to sum up all up from the x-ray and then ask for the CT. But well done.
So
yeah.
I was thinking, because it's unilateral, like I didn't the differential ciliary dyskinesia or
so that's usually, so when I was saying it is unilateral, so that's usually post-infective. So the answer here is post-infective. So childhood whooping cough would cause such an appearance because it's unilateral. But you could just show off the examiner that, other causes of lower zone bronchiectasis would be primary ciliary dyskinesia, but I'd expect that to be bilateral. Alpha-1 antitrypsin, again, that's bilateral. Could it be an oblit? So just show off that, your differentials for lower zone bronchiectasis. So you're just going via lower zones, but this is just post-infective bronchiectasis.
It sounds good. Thank you so much.
No worries. Yeah. So shall we swap, go to candidate 3? So I don't know, Dr. Ismail, we're already half an hour, and I'm aware that you need to do your...
Take your time, yeah, boss. Take your time.
Okay, thank you. So we'll just... we'll go to candidate 3, if that's okay, yeah? Candidate 3, are you there?
Yeah.
Yes. Yes. Okay. So, so this is a young patient who presented. So this is a young patient who presented with. Let me just give you the correct history. So this patient presented with just recurrent cough and recurrent chest infections.
Sorry, I did his history.
Sorry, so this is a young adult patient. So he's in his 30s, so 30-year-old female who presented with recurrent chest infections.
Recurrent chest infection. Okay, I'm presented with the frontal chest radiograph of 30 years old female with the recurrent chest infection. There is, I can see there is bilateral, there is left upper lobe tubular opacity. See, the right lung is unremarkable. The left hilum is bulky. The heart is unremarkable. The bones are unremarkable. No evidence of pleural effusion, no evidence of pneumothorax, no pneumomediastinum. The lung volume is maintained.
Okay. So can you see anything else apart from that opacity that you've described?
Okay. I think there is a diffuse interstitial opacity.
So is it an opacity or is it a hyperlucency?
It's hyperlucency at the left upper lung.
Yes. Yes. So it's hyperlucency, upper lung with a tubular branching that you've seen within it. And you said that the lung volume is maintained.
Yes.
Nothing else significant. So what's your differentials?
Giving this appearance, it could be upper lobe. So my differential is, I think it's something maybe congenital.
Okay, yeah. So what kind of congenital stuff that you think of?
Congenital upper lobe emphysema.
Congenital. Okay, so it's not congenital upper lobe emphysema, but so whenever you see hyperlucent, lung, what's your differentials, or how would you tackle it? Like, what's your approach?
Okay, so it's confined to the upper lobe. Actually, let me think. The upper lobe.
Okay, so whenever you see a hyperlucent lung, you just need to think of, the lung volume is maintained. Can you see any surgical? Could it be like part of a pneumonectomy, but there are no surgical, any previous evidence of surgery, and the lung volume is maintained? So what else could it be? So shall I give you a CT? Maybe it will help you.
Okay.
Yeah. So that's let me scroll through.
Okay, so it's there is increased lucency within the upper lobe. No evidence of no cystic lesions seen. So I'm thinking about emphysema.
Okay. So what else could it be apart from emphysema?
Okay, the blood vessels. Okay, the vessels is maintained. This is
Yeah. So yeah, the vessels are maintained. What do you think about these? These bronchial branching here. What are they filled of? Okay, so I'll just help you a bit. So these are bronchoceles. So there is bronchoceles with area of hypoattenuation. So that makes you think of what bronchial atresia.
Yes, bronchial.
Yes, bronchial atresia. So here the giveaway. So you've seen the hyperlucent, okay, and then as Dr. Curtis says, check that the vessels. So there is no positive. So the vessels are normal. So and here on the CT, so it's an area of less ventilated lung with evidence of bronchoceles. Can you see these bronchioles are
Yes,
all?
I can see it.
See it, yeah. So this is just a case of bronchial atresia, and this is just nuclear medicine. And then patient here had surgery. So how do they treat them? Because these areas are much prone to repeated infections. So they just tend to do, a lobectomy. So this patient underwent a lobectomy. We can see the clips. We can see the reduced volume by detenting of the diaphragm. Okay, so that's a bronchial atresia. And so this is an elderly patient who presented with shortness of breath.
Okay, presented with the frontal radiograph of chest radiograph of elderly patient with shortness of breath. There is a diffuse interstitial opacity, more at the lower zones bilaterally. Both hyla are bulky. The heart the heart volume is unremarkable. The bones are unremarkable. There is no evidence of pleural effusion, no evidence of pneumothorax. Given this appearance, thinking about interstitial lung disease, maybe usual interstitial pneumonia.
Okay, so in usual interstitial pneumonia, is it unilateral or bilateral, the abnormality? Bilateral. And here the abnormality is it unilateral or bilateral?
I see it's bilateral, but it's more at the right side.
Okay, yeah, so it is unilateral. Let me just give you the CT. So what's your differential here? So if you have just unilateral interstitial lung marking, so this is normal, just it's an elderly patient and we tend to see these coarse markings. But if you can see here, it's quite florid. So this is interstitial lung marking, which is unilateral. So what's your differential?
I'm wondering if the patient has any history of operation.
So no history of operation. And if I tell you that this patient has history of heart failure, does it help you?
Heart failure?
The patient has history of heart failure, yes.
Okay. So in a history of heart failure, I'm thinking about pulmonary edema. I think it would be also bilateral.
So it's usually bilateral, but this is a case of unilateral pulmonary edema in heart failure. Okay, so this is interstitial lung marking or interstitial changes within one side. So this is unilateral. So your differential would be could it be lymphangitis carcinomatosis? It's an elderly patient. So you just need to tell the examiner this could be lymphangitis, or it could be, unilateral pulmonary edema. And the most common unilateral pulmonary edema, but usually in the upper lobe, what valvular disease would you think of? So mitral valve regurgitation. Okay. So your differentials for a unilateral interstitial changes would be lymphangitis, and it could be unilateral pulmonary edema. It does happen, but you'd say to the examiner, I'd expect it bilateral, but it can happen unilateral. So that's just a case of a unilateral pulmonary edema in a heart failure. Okay. And if you see unilateral pulmonary edema involving the upper lobe, then you say the examiner that this is highly associated or it is associated with mitral valve regurgitation. Okay, so you tell the examiner that you just want to review the history. I think this patient was treated, and so that's his CT. I think just they're just static images, but it's not clear. So And usually with diuretics, they repeat the X-ray and it's plumb normal. Okay, so an interstitial, we said UIP pattern would be bilateral, isn't it?
Yeah.
I'm giving you this one, so I think they're a bit difficult cases, but this is, yeah. So this is an elderly patient. So this is a 70-year-old patient who presented with shortness of breath.
Okay, I'm presented with the frontal chest radiograph of 70-year-old male with the shortness of breath. Okay, there is a decreased lung volume at the right side with shifting of mediastinum to the right side. There is blunting of right costophrenic angle. No evidence of mass lesion. There is bilateral interstitial increased interstitial marking. And I'm going to check. Okay, the left the heart is remarkable. I'm checking the bones.
So nothing in the bones. So the bones are fine.
Okay, bones are fine. So giving this appearance, and at old age, I'm considering. I think I'm suspicious of something at the hilum.
Okay, so the hilum is fine. If I tell you the hilum is fine, yeah. So
Yeah.
you've seen unilateral changes. You've picked up nicely that there is reduced lung volume and there is some increased interstitial marking, and it's just only one lobe. So what would you do next, or what would you be thinking of? So what does it look like, you know? So interstitial lung marking with reduced lung volume. It's epicobasal. So can you see it's more basal, basal changes?
Yes, and it's unilateral.
So yes, and it's unilateral. So what would you think of? So just ignore the unilaterality for the moment. So reduced lung volume, epicobasal with subpleural reticular changes. So
I will think about usual interstitial human.
yes, UIP, yes. So
Yeah.
you're right. But this lung looks okay-ish, yeah? Looks a bit normal. So
yes, it looks normal.
yes.
I'm wondering if there is any history of operation.
Yes, so there is history of operation.
Okay. So in my routine practice, I will correlate with the previous images and with the clinical history, and usual interstitial pneumonia will be on the top of my differential.
With how can you explain that the left lung is normal?
With the history of operation.
Of what kind of operation?
A lung transplantation.
Lung transplant, yes. So well done, yeah. So this is just a UIP. This is a favorite in the exam. So, you know, UIP, you'd expect it to be bilateral, but this is unilateral. So this patient did have, you know, a lung transplant. And just going here on the CT, you could see the honeycombing very clearly, and the honeycombing is 100% specific if it involves more than 5% of the lung volume. So if you see honeycombing, which is involving more than 5%, this is highly specific for UIP. And
5%?
Sorry, more than 5%. If it's involving more than 5%, it's highly specific. And then you want to tell the examiner that I want to see the soft tissue window just for looking for any evidence of, you know, clips, which just indicating, you know, previous lung transplant. Okay, so I think we've almost took 50 minutes, and I'm sure everyone is keen to attend Dr. Ismail's session. We could carry on next time if you guys find it useful. So I'll hand over to Dr. Ismail, if that's okay. Anyone has any question?
Assalamu alaikum. If you want to continue, Dr. Nuha, it's okay. It's okay.
Yeah,
no,
Dr. Ismail, everyone is here just for you. You know what?
No. MashaAllah, MashaAllah. Your session is very wonderful and very educational. MashaAllah, MashaAllah. Continue the remaining cases, and I'll give them 5 minutes to relax. Okay?
Okay.
MashaAllah, your session is very good. MashaAllah. Thank you. Thank you.
Okay. So shall we next candidate then? Shall we go?
Hello,
Hi, yes, hello.
I'm candidate number 4.
Hi, candidate 4. So I'll give you this. She's a 62-year-old female with acute shortness of breath.
Yes, I have been presented with a frontal chest radiograph for an adult patient with history of acute chest pain. My main finding, I can see that there is multiple post-embolization changes seen at both lung fields. I can also notice that there is tubular airspace opacity seen involving the right lower lung lobe associated with feeding artery and draining vein, representing pulmonary AV malformation, arteriovenous malformation. And I can see that there is also changes of sternotomy wires. So in my routine practice, if this patient have previous images on the system, I will compare these images and see why this patient has acute chest pain. Also, I want to see the liver for this patient to see if there is associated liver AV malformation. And I also will see if, yes. So I have been presented with CT axial images for the chest taken in arterial phase. I can see that there is multiple embolization, as we said previously, and I can see that. Can we change it to the lung window, please? Yes. Okay. So we're starting from top to bottom. Okay. I want to see the right lower lung lobe, if it is possible. Yes. I can see here that there is tortuous blood vessels and with the draining, with the feeding artery and draining vein, consistent with the AV malformation. I can also see that there is multiple nodules in the left lung. Yes, here. Yeah.
So you've seen multiple nodules, you've seen multiple AVMs with previous embolization clips. So what's your diagnosis?
Yes, because it is multiple, I am thinking about Osler-Weber syndrome. So I will carry this furthermore by checking the liver for this patient. And also I want to see if there is any complaining of, yes, the liver.
Yes. So nothing in the liver. So
yeah. Yes. In the liver, I can see that there is no enough contrast for judgment, but however, I can see that there is contrast in the hepatic veins. It's supposed not to be seen in this phase, so this is more likely to be a reflux of contrast from this, from the, let's say, the right atrium. There is reflux of contrast. I want to see if there is any venous phase for this study. If not, I will do ultrasound for this patient to see if there is any AV malformation.
Okay, so this is, yes, so this is a case of Osler-Weber-Rendu syndrome. So there is a very important negative. So I told you she presented with shortness of breath. So these patients are more prone to pulmonary hemorrhage. So this is a very important negative that you should have commented on from the X-ray. So
yes.
Yeah, so that's how they acutely present with bleeding. So you could say that I can't see any evidence of peri-hilar opacification, as these patients tend to present with pulmonary hemorrhage. And another important finding, that's heart size. So perhaps maybe it's not the ideal projection, but they tend to, these patients tend to present with high cardiac output failure. So important thing is pulmonary hemorrhage in the acute setting. I think Dr. Ismail before said that, you know what, check for, you know, important or emergency things, but just pulmonary hemorrhage, that's how they tend to present to A&E. And heart failure, they present with cardiac output failure, high cardiac output failure. Okay, so I'll give you this one. I think this is a So this is a 30-year-old female patient who is having a CT for recent lung abscess. It's just a follow-up CT for lung abscess, and patient is now well.
Okay, so I have been presented with chest CT scan with IV contrast for a female patient with history of abscess follow-up. She's doing well. I will take a brief look at my study, then I will go back to my finding. So in this study, I cannot appreciate any filling defect within the cardiac chambers. Also, I can see that the pulmonary trunk and both main pulmonary arteries appear patent with no evidence of filling defect representing pulmonary embolism. I can see that the thoracic aorta appear within normal diameter and showed no aneurysmal dilatation or dissection. And in my routine practice, I will change this window for the lung window to see if there is any changes after the abscess episode.
Okay, yeah, go to the lung window.
Okay. Yes. So in this lung window, I will go briefly to the top of the study. The main abnormality, I can appreciate that there is multiple honeycombing area noted in the medial aspect of the right lower lung lobe. The rest of the lung. Yeah.
Sorry to interrupt. Honeycombing. So what do you mean by honeycombing? Can you see honeycombing here?
Yes, it looks like a honeycombing, but it is seems large in size.
Okay, so what's a better word than honeycombing? It's that you can use here for this description.
Yes, it could be emphysematous.
Other than emphysematous, I've showed a case on X-ray and then on CT. So we've called it cystic bronchiectasis, isn't it?
Cystic bronchiectasis.
Yes. Yeah.
Okay, I can see that there is a change, localized changes of cystic bronchiectasis in the medial aspect of the right lower lung lobe. However, the rest of the lung parenchyma appear clear. There is no evidence of lung nodules. No evidence of lung nodules, masses, or any cavitary lesion with thick wall representing abscess formation. However, in this cases of follow-up, I would like to see the previous images for better comparison of this patient. Second of all, in this case, I cannot see any pleural effusion or any hilar or mediastinal lymph node. So I want to see the previous images for better comparison of this patient.
Okay, so is there anything? So this patient is having recurrent, so she's quite young with recurrent lung abscesses. So does it make you think of anything? So what would you look for if she's that young with recurrent repeated history of lung abscess? Is there anything in specific that you would want to look for, actively look for? Perhaps why is she more prone to these lung abscesses?
Yes, it could be due to history of foreign body.
Okay, so there is no history of foreign body, so you'll tell the examiner that I'll look at the trachea. It doesn't look like there is any other foreign body. Anything else that makes them more prone to infections?
The bronchiectasis.
So apart from the bronchiectasis, so just go back to the axial arterial phase, so the soft tissue window. Just have a closer look. Can you see anything?
Yes, there is a blood supply, direct blood supply from the aorta.
Yes. So
this blood supply giving the appearance of or suggestive of sequestration in the right lung, which is predisposing for multiple abscess in this patient.
Yes, so it is pulmonary sequestration. So whenever you're given a history, a young patient, and the history is a bit odd with recurrent infection, recurrent lung abscesses, always be suspicious of, pulmonary sequestration. So what are the types of pulmonary sequestration that you know of?
We have two types, extralobar and intralobar. Extralobar usually seen in pediatric age group, while intralobar is seen in the adult age group. Extralobar gets both types gets blood supply from the arterial system, but extralobar draining into the pulmonary veins and the intralobar draining
So she's having repeated infections, she's developed cystic bronchiectasis, and the primary cause for all these changes was just the sequestration. So, okay, so this is I think we've done this case, isn't it? So this is an 80-year-old male who presents regularly to the respiratory clinic with recurrent shortness of breath.
Yes, I have been presented with a frontal chest radiograph for another patient with recurrent chest pain. I can see that there is multiple nodular or reticulonodular shadowing seen at both lungs. The lung volume appear maintained. There is no evidence of pneumothorax, pneumomediastinum, or pneumoperitoneum could be seen in this study. There is no pleural effusion. The cardiac shadow appear normal, no cardiomegaly. Also, I cannot appreciate any retrocardiac shadow. There is no hilar enlargement. So my interpretation for this case is reticulonodular shadowing. Without any bony abnormality could be seen. No ribs crowding or expansion between both of them. The lung apices are very clear, and the skin for this patient, there is no lesions seen in the skin of this patient. So I will combine my finding to the referral doctor. And
so what's your diagnosis? What's the diagnosis?
Yes, it is these are the diagnoses for reticulonodular shadowing. It could be due to interstitial lung disease. It could be due to infectious inflammatory process. I will carry this furthermore by doing high resolution chest CT scan for better assessment.
Okay, so just going back, so you said that the changes are reticulonodular. Is there any zonal predominance here? Can you see it much more upper, mid, or lower?
They are, yes, they are in the no zone of prediction. I can see that there is nodules in the upper and mid and lower.
Okay, but predominantly, where are the changes?
Predominantly, maybe in the mid lung zones.
So you're talking about these.
Yes.
Can you have another look at the apices? What do you think about the lung apices here?
The lung apices, yes. I can see a few nodules. Can you see my precursor?
No, I can't see. So you're talking about these.
I can see nodules, but I think they are more frequently noted at the middle lung zone. I can see a few of them in the upper lung zone, but not as much as the mid lung zone. Maybe with the high resolution, it could be more useful in detection and characterization of these nodules.
Okay, just bear with me. I think I've lost my screen. Yeah, it's just here. Okay, so if I tell you, can you look at the apices here? Can you see just a pacification here? Perhaps maybe can you see these ribs, rib crowding? So evidence of rib crowding here. So
okay.
There is. I tell you that there is evidence of volume loss here within the apices, and just look at these opacities here. So if I tell you this is, upper lobe, bilateral upper lobe volume loss with apical fibrosis, what would you think of?
Ankylosing spondylitis, maybe.
Can you see any features of ankylosing spondylitis here?
No, I cannot. Yeah.
Okay. Yeah. So what else? What else here differential?
It could be due to cystic fibrosis, ankylosing spondylitis, abscess formation, but it could be due to sarcoidosis.
Okay, so there is no evidence of lymph nodes here.
No, bilateral symmetrical, yes.
It's always the last option when you say it, it's the diagnosis. What else can cause bilateral apical fibrosis? Conglomerate apical fibrosis with volume loss with no evidence of lymphadenopathy.
It could be due to infection, pneumocystic carinae, maybe TB.
Okay, so yeah, so TB would be a valid option. So this is a case of silicosis. Okay, so always remember silicosis, because we still see them here in clinics. They're still, we see the elderly patients who are in their 80s, 70s, who were previously coal workers, in the mines. So we have, silicosis. So this is a case of silicosis or pneumoconiosis, which is just a lung disease secondary to exposure to inorganic. So the giveaway here is the pattern. So you've nicely picked it up that it looks like an interstitial lung disease to you. But the whenever you see interstitial lung disease, always talk about whether it's upper, mid, or lower. So see where is the main predominance. So here there is bilateral opacification. So this is bilateral apical conglomerate fibrosis. And your differential should be sarcoid, but there is no other features to suggest sarcoid here, and silicosis. So always remember silicosis and how they are treated. So these patients also go to the MDT, so they get discussed in MDTs, and they have regular follow-up in their respiratory clinic. So this is a 40-year-old a male. I think the history was given as having fever, so shortness of breath for the last 2 to 3 months, with fever and cough and no hemoptysis.
Yes, I have been presented with a chest radiograph for an adult patient with fever, cough, and shortness of breath. The main abnormality, I can see that there is soft tissue mass lesion seen in the lateral aspect of the right lung at the mid zone. This mass lesion shows obtuse angle with the chest wall, and most likely it is pleural in origin. Otherwise, there is airspace opacification noted in both lungs, without any pleural effusion or significant lymph node enlargement. So the main finding is a large pleural based mass lesion in the right lung, which I cannot see any cavitation within it. There is no calcification. I can see that there it is it is not solitary. I can see another yes, in the previous precursor, I didn't see it. I can see that there is two pleural right lung lesions. I cannot appreciate obvious left side. It could be one. I can see. Yes, it could be this another lesion. So to summarize my case, this is a case of pleural-based bilateral lung lesion. In my routine practice, I will ask about the occupational history of this patient, and I also will look for any calcified plaques seen within the mediastinum.
So this patient is 40 years old, so it's a young patient.
Yes.
So, yeah. And the distribution, so you've picked up this nicely, you've picked this, and you've picked, all these changes. So can it just, is there any one unifying pathology that you can think of that gives you, peripheral airspace opacities in a young patient with chronic history?
Yes, I am thinking, generally speaking, about, other than the occupational disease, about metastatic process. It could present like this, and also in the cases of mediastinal mass lesions, such as malignant thymoma, it can be presented like this.
Okay, so that's the CT. So does it help you? Yeah.
Yes, this is a high resolution CT scan. I can see that there is widespread ground glass changes noted peripheral both lungs, and more pronounced at the left upper lung lobe, with mild changes of bronchiectasis. This could be due to scleroderma, because yes.
Okay, so so this is a chest X-ray. So the findings here are multiple regions of airspace. So there are airspace opacities. They have peripheral distribution. Nothing else on the chest X-ray here. So on the CT, there are peripheral areas of airspace consolidation. So they're just quite peripherally. So if you have peripheral airspace consolidation throughout both lungs, but predominantly it's in the upper and middle lobe. So what would you think of? And if I tell you that the patient has, like, you know, eosinophil counts is really high, peripheral eosinophil counts are markedly, he has marked eosinophilia in the alveolar lavage, what would you think of?
Eosinophilic pneumonia.
Yes, so it's chronic eosinophilic pneumonia. So this is a case of chronic eosinophilic pneumonia.
Yeah.
So it's a bit difficult, but the distribution. So if you have peripheral distribution of airspace opacities, so one of your differentials, it could be like pulmonary infarct. So that's one of the differentials. Could it be chronic eosinophilic? So you could tell the examiner, could it be eosinophilia? Could it be pulmonary infarcts? And the giveaway here is on the CT, which again confirms just the distribution. And you tell the examiner, these are my differentials. I'd like to correlate with the bloods. And if I want to know if the patient has any eosinophilia or any history of any other previous history, that would help you. But this is just a case of chronic eosinophilia. So I'm just quickly going to recap about what we've seen so far, just for everyone else. So this is a case of a round pneumonia. Always think of round pneumonia in pediatric patients. You can't say that you want to have them followed up just to make sure that it's resolution. Always think of foreign bodies in pediatric patients. Here is playing of the ribs is the main finding that just picks up the diagnosis. And we've discussed that you need to do an expiratory film if the child is cooperative. And if the child is not cooperative, then you do the decubitus films. This was a case of a middle. So whenever you see the right heart border ill-defined, you have three diagnoses: middle lobe collapse, middle lobe consolidation, or pectus. And you need to show the examiner that you're looking for any evidence of pectus, but there is no evidence of pectus. So that's the three main differentials whenever you see an irregular heart border. Here, always look at the supine and look for a deep sulcus sign. This is a Klebsiella, and the giveaway was the bulging fissure. And this was ABPA, allergic bronchopulmonary aspergillosis, in patient who has hypersensitivity. You ask the examiner, you want to know two things, which is asthma, mainly associated with asthma, and cystic fibrosis. And you could tell the examiner, I can't see any evidence of cystic fibrosis or chronic changes. This is the case of hypersensitivity pneumonitis, so perihilar alveolar infiltrate. And the giveaway was on the CT, which showed air trapping and ground glass nodules. And the management is referral to the MDT, because it needs history as well as radiology, as well as bronchoalveolar lavage and pathology. This is the case of the cystic bronchiectasis. This is really one of the favorite cases. So this is a case of cystic bronchiectasis, and we've discussed how to pick up cystic bronchiectasis on X-ray and on CT, and we've gave the differential for lower zone bronchiectasis. This is a chest X-ray, so hyperlucent with branching opacities, no lung volume loss, and that's just a case of bronchocele, bronchial atresia. And this was a case of, so it's a unilateral interstitial lung changes. So we've said two mains. So we can have a unilateral pulmonary edema in heart failure, or it could be lymphangitis carcinomatosis. So these are two main differentials, and we've discussed the management. And this case here is, again, unilateral interstitial changes. And we've discussed apicobasal, so that's the giveaway that this is a UIP pattern, but the other lung is normal. So always think that there is a lung transplant. And that was a case of Osler-Weber-Randu. So we've discussed the most important negatives is say that there is no pulmonary hemorrhage and comment on the heart size because they are more prone to cardiac, high cardiac output. And that's the case of the repeated abscess. So whenever you have a history of a young patient with atypical history or repeated history, just look for a feeding vessel to suggest that this is sequestration. Again, that goes to MDT. And I think this is just a case of upper lobe or apical fibrosis with volume loss. So the differentials would include, as candidate 4 said, so TB, Angst, but always remember silicosis in your differential. And that was just a peripheral distribution of airspace opacities. Always think of eosinophilic pneumonia. So I'll hand back to
Dr. Nuha. Thank you.
No worries. Any
Thank
questions?
you, Dr. Nuha, for this very nice collection of cases. Any questions for Dr. Nuha?
Doctor, please. Doctor?
Yes, Dr. Nuha.
Yes, please. Please, how to manage pleural effusion in pediatric age group?
Okay, so pleural effusion in pediatrics age group, it's usually the commonest cause is post-infective, like it would be like a parapneumonic effusion. Majority of the cases, they tend to resolve just spontaneously. So they rarely get complicated. So when I say rarely get complicated, sometimes it might develop into an empyema, but they usually just whenever the infection resolves, it gets resolved unless it's get complicated. So if it develops into an empyema, then they just insert a drain. But usually we rarely see it, but it is seen, but rarely. So it's just usually they resolve by themselves. Like it's not like adults where they just present with a massive. So if they present with a massive pleural effusion, just always think that there is an underlying abnormality much more than in just a simple infection.
Thank you, doctor. Thank you.
Doctor Nuha, excuse me.
Yeah.
Yes, the last case I see in CT the atoll sign. Why I didn't diagnose it as a cryptogenic organizing pneumonia? حاضر بكره عندك نهار يا داد؟ يا لهوي طب ما قلتليش ليه كنت خدتها؟
Okay, so so it could be in the differential. I think, you know what, it could be mentioned in the differential. So this case, it was just picked up from the so the diagnosis. So it is a valid, it's a valid differential diagnosis, but this was just picked up from the bronchoalveolar lavage. So that's hence the diagnosis, but it is a very valid, yes, differential. I think Mohammed Rifat has his hand up. Yes, go ahead, Mohammed.
Yes, Dr. Nuha. This pulmonary sequestration, intralobar, extralobar, the treatment the same?
So the treatment, I'm not sure, Dr. Ismail, can you just highlight a bit more?
No, I will escape. I want to know.
So what I know here, what they do in the UK, they get referred to the MDTs and they get discussed. So that's hence they have this discussion. But usually I know that they get treated surgically, but I'm not sure if they're the same, but I can definitely ask for you and get back to you if that's okay.